Hello, and we welcome you to our inaugural Thoracic Surgery Clinics podcast. Thoracic Surgery Clinics is a quarterly publication consisting of review articles devoted to a central topic important to general thoracic surgeons. I'm John Vasallo, the managing editor for the series here at Elsevier, and for our first podcast, we will be discussing the February 2022 issue on social disparities in thoracic surgery. Here to discuss topics such as workforce disparities, recruitment issues, lung screening, and esophageal cancer will be our consulting editor of Thoracic Surgery Clinics, Dr. Virginia Lytle, Section Chief of Thoracic Surgery and Medical Director of Thoracic Surgery at Intermountain Healthcare in Murray, Utah. Joining her will be the guest editor of the Social Disparities issue, Dr. Sherry Erkman, Professor of Thoracic Surgery and Program Director of Lung Cancer Screening at the Lewis Katz School of Medicine at Temple University in Philadelphia, Pennsylvania. Welcome to both of you, and over to you, Dr. Lytle.
Thank you, John, for the opportunity to discuss this issue. It's very important and pertinent to current climate, socially, and in the medical world, of course. So thank you, Sherry, for joining us and for taking on this topic of social disparities in thoracic surgery. I know you seem very passionate about this topic as well as lung screening. And I'd just like to ask you, how did you get interested in focusing on social disparities in thoracic?
Thank you, Dr. Lytle. And also thank you to Thoracic Surgery Clinics for having the vision and courage to commit to learning about this topic. It's very timely, and I appreciate that. So I started to learn about disparities and really get involved with disparities looking at my time at Dartmouth when it was largely access and transportation to a high volume center. And that barrier was really hard to overcome. And they really thought that there was something more structurally that we could do to facilitate that. And then coming to Temple, a totally different set of barriers to patient care. And I understood how complex the issue of disparities is and really sought to pursue it both in education, research, and my clinical practice. So that's how I started out.
Well, great. And I'm really glad you have taken this on. And I think you also are collaborating with some of our other thoracic surgeons throughout the country on this topic. So I'm hoping that as a collaborative group, we can actually affect change because there really is a need. And when you read the contents of this issue of thoracic surgery clinics, you can appreciate that. So let's see. Let's start off with there's basically many wonderful contributions that we obtained from our invited authors, but we've selected about 4 topics we can focus on in this issue. So let's start off with the social disparities in lung screening submission, and you co-authored this with Drs. Rahman, Yong, and then Betty Tong, who also is very passionate about lung screening and is a leader in that area in our field. So we know that folks of lower socioeconomic status or government-based insurance are more likely to be diagnosed with lung cancer and less likely to get screened. Can you suggest the best approach to increasing awareness and educating the population about the benefits of screening?
Yes. So really, where we start out is that we know from work from you and Dr. Suzuki and Dr. Tong's group at Duke, we know that low-income urban and rural communities are not being screened, but we still don't have enough data to understand who and why and what are the real barriers to screening among all people. We're really only getting about 3 to 6% of eligible Americans participating, and it's even worse when we look at socioeconomic groups and socioeconomically disadvantaged groups. So first and foremost, we need more studies. We need more understanding of who's failing to screen and why. And based on this data, we need to create population-specific approaches. So addressing education, as I discussed, transportation and follow-up care is very different, whether you're in a rural community of New Hampshire or a Spanish-speaking community in Philadelphia. Every population needs a different approach, and it has to be based on evidence derived from studies looking at these barriers. So a third, we need to have credible messengers for patient education. If we can recruit community educators, nurses, and doctors from the population we're trying to screen, we'll be much more effective in educating about lung cancer and lung cancer screening.
Yeah, I totally agree. Certainly engaging the community leaders, church leaders, folks in the community that this population trust and will listen to. So commenting on or can you elaborate on the geographic access, some solutions that you had thought of when you were up at Dartmouth in particular?
So, we have actually looked at telemedicine. Dr. Magarinos, one of our residents, has looked at implementing telemedicine to deliver shared decision-making, smoking cessation, and to even report results of lung cancer screening to try to overcome transportation barriers. And this is something that really COVID-19 forced us to do, and now I think it will become part of our future. There are a lot of creative ways to overcome barriers. One thing that we did is to create a program whereby people can get screening, smoking cessation, shared decision-making results, everything in a single visit, so that if they do have one visit, they can get everything done, and it's not piecing together several appointments. So there are a lot of novel approaches, and again, each thoracic surgeon and each lung cancer screening program really needs to partner with their community to identify how to overcome the barriers.
Yeah, and it's an opportunity to collaborate with our other providers and our colleagues in other specialties too, who have these challenges reaching their patients. In particular, one thing, I know even in Boston, we had populations who didn't have access to smartphone technology. They couldn't even do televisits very well. So that's another barrier, but something that we could collaborate on locally. So let's move on to the topic of esophageal cancer. So Dr. Alan Pickens addressed this. He talked about racial disparities in esophageal cancer and his contribution. He made a key point that minorities undergo fewer esophageal resections, presumably for curative intent, and they also have the worst overall survival. Are there approaches for improving access and awareness to socioeconomic minorities with regards to lung cancer that we can apply to those who might be at risk for esophageal cancer or showing signs and symptoms of esophageal cancer?
Yes, I think, you pointed it out that the startling message that Dr. Pickens delivered was that non-white and low socioeconomic groups had underutilization of surgery, that African Americans were not only referred at a lower rate, but they engaged surgery at a lower rate. So this is really a problem of educating clinicians across the board on the absolute need to consult surgeons in the setting of esophageal cancer. The decision to pursue or decline surgery really must include a surgeon. And we can all benefit from implicit bias training and making sure that we're counseling patients based on their story and the evidence. But I think it's a shared group to be front and center with our collaborating clinicians, and really to look at our own practice, that we are offering surgery based on evidence and patient story and not on bias.
Yeah, excellent points. Okay, so moving into the area of health disparities and recruiting patients to research. Your former colleague, Dr. Hassan Charles, I think you work together, but at least you're both Dartmouth gals, made several key points in her contribution, one of which was barriers to diverse research recruitment and enrollment, and some of the barriers including cultural insensitivity and medical mistrust from historical events, of course, and provider bias, as you just touched upon briefly. So can you suggest concrete actionable items to try to reduce this besides the implicit bias training?
It's a really good question. And we were so fortunate to have Dr. Charles and Dr. Winsey contribute to this work. And they emphasized that without diverse recruitment, producing evidence and subsequent healthcare decisions, that all of this will be slanted, unfortunately, toward more disparity. So they gave a lot of evidence behind this fundamental concept that will power, hopefully, the movement to increase diversity in recruitment. So their recommendations were to implement diverse recruitment in the study design. So this means in your budget, in your personnel, in your execution of the study, it has to be front and center, and that recruiting underserved and underrepresented populations must be a priority from the very conception. And from there, secondly, they, as we discussed with lung cancer screening, they advise using credible messengers and developing community ties to gain trust and participation. And perhaps not just your study with your community leader, you should really partner with other studies so that people don't feel like you're selling one product. You can go to the community and say, these are many, many studies that we're offering. You can pick and choose what's right for you, and really being efficient about community leaders, community relationships, and developing that trust. And, I think, I'll ask you, but I think there really has to be an appetite for researchers to study and publish in health disparities. So we as a community of thoracic surgeons have to prioritize health disparities in our publications, in our presentations, and this has to be a priority from us as a profession, not only from the social justice standpoint, but also as it improves care. But that comes from leadership, that comes from top down. And I'm interested in what you think about, the appetite for this work.
Yeah. So my impression is, unfortunately, as surgeons, we're so busy all the time that you either something has to plant that seed in you, either a particular experience with a patient and feeling terrible that they didn't get the right care, or like Dr. Raja Flores, what motivated him to run for mayor of New York City was because of some of the disparities some social issues he saw with his patients in their New York housing, and maybe they were getting infections because of the housing, and he realized the only way to make a change was to run for political office. Now, obviously, that's not very feasible for all of us, but I think engaging many of us have residents who do research, right? General surgery, if we work with general surgery residents, engage them to select these topics, collaborating as you have with other thoracic surgery friends in the country, so that we can spread the wealth of information and interest. My former partner, he was at Boston Kay Suzuki. He was at Boston Medical. Now he's at Inova in Virginia. So that's kind of like he's planting a seed, sort of like or a coconut landing on an island, and let's see that palm tree grow. Regardless, just kind of working together, and I think it would be wonderful if we could have like a dedicated collaborative group, but encouraging our trainees to do research on those topics, that they can carry on that passion once they finish their training. So yes, I wholly support all your ideas there. So let's see. So disparities. Okay, so you invited Dr. Mimi Sempa from Indianapolis to write about social disparities in the thoracic workforce. And, as women cardiothoracic surgeons, this is kind of very near and dear to our hearts. But it's not just the women minorities; it's also the paucity of Hispanic CT surgeons and blacks. I think it's 5% and 3% respectively. So we're seeing improvement, as I said, in the number of women that are going into CT surgery, albeit at a slow rate, but it's, we're engaging young women. However, how can we make the field more culturally inclusive for, say, the racial minorities?
Well, I think we can leverage the progress that we made with women in thoracic surgery. I think the leadership of Shanda Blackman and now Dr. Lauren Kane with the organization Women in Thoracic Surgery, this has been a critical platform to advance not only women, but a diverse community of thoracic surgeons. And we really need leaders like Dr. Sepa, who authored this work, to call out the painful truths about disparity in our workforce. We didn't get to this disparity of workforce because of one problem, and it won't be solved with one solution. And so my wish is that we can work on an entire continuum of a thoracic surgeon's career to increase recruitment and retention of a diverse workforce. So undergraduate students and medical students who are underrepresented in medicine, they should have exposure and encouraged to pursue thoracic surgery. And based on some recent AAMC data, we're looking at integrated programs actually having more diversity than our traditional fellowships. So we are making some progress, but we have to create an inclusive environment for our residents as well. And Dr. Sepa published work showing that 90% of female residents in thoracic surgery reported sexual harassment. And interestingly, 32% of male respondents also reported sexual harassment. So this is unacceptable. We have work to do. This is not a constructive environment for learning or patient care. And definitely the environment, the clinical learning environment of our residents must be improved so that we can retain the people who have committed to thoracic surgery. And at the attending level, we have to address pay gap. Across medicine, women are paid 73 cents on the dollar. And this is even worse in surgery and subspecialties. So the AATS has asked Dr. Merrill and me to work on finding this data for thoracic surgery and really identifying the ways that compensation, whether it's in salary or referrals or opportunities and leadership, how this compensation can be more equitable. So there's so much work to do, and it really requires all of us committing to the importance of diversity. And we've made some progress, like you said, in women, but we just don't have the data in regards to Black, African American, Hispanic, and other racial and ethnic minorities. We just don't have that data for our specialty, which we need.
Wow, that's really exciting to hear about what Dr. Merrill and you have been tasked with. So I agree wholeheartedly that the gender inequity in salaries is just inappropriate and needs to be changed. So I'm glad that you guys are taking that on, and I can connect you with some folks who might be able to help too. Let's see. So next topic, since we have a little more time here, you were very involved in this issue, and also to the point where you senior authored, basically a primer on health policy, which is excellent, of course. And a lot of us don't know the history of all this, so it's great to have it summarized. So what are the key ways that we as thoracic surgeons can mitigate health disparities on the local level?
It's a very, very difficult question. So really I had direction from Dr. Nunheim and Dr. Magarinos, and really looking at health policy at the local level demands an understanding of what it is on the national level. So we looked to understand health policy in terms of executive orders, legislation like the Affordable Care Act and Supreme Court rulings, which are now becoming more influential in patient care. And by looking at landmark events in healthcare and health disparity through these avenues, we can see how we as citizens and we as surgeons can potentially impact health disparities. And not all of us can be as involved as Dr. Nunheim, but I think we can really start to learn that we do wield a certain amount of responsibility and potential to influence our communities as being thoracic surgeons. And it's difficult, at least this is as you said, a primer, just to see different ways to influence, whether it be through advocacy with your own legislators or by getting on health policy committees to start to influence that. All of this is critically important. And I don't know about you, but I did not receive specific education or training on how to interconnect with the community. I really grew up with the notion that as a thoracic surgeon, you work within your four walls and do the best that you can. But just as there are social determinants of patient outcomes, there are social determinants of how we deliver care. So I don't really have a good answer for you on how we can work at the local level, and perhaps you have some thoughts.
I think basically summarized it, bits and pieces there, that we just being engaged and having a particular clinical program that requires you to have direction and focus. So your lung screening program, for example, where you want to increase the number of minorities being screened, and that gets you actively engaged with the community and community leaders, and then you can also learn what are some of the other challenges, right, and problems in medicine and surgery, but particularly thoracic surgery we can focus on, that we may not be aware of. I mean, yeah, you can't sit in your silo and expect to make change. That's an obvious one. But I think having a focus with a particular clinical program is one way to approach it. And of course, engaging with our other community leaders. And I feel obliged to make a plug for donating to the STS PAC, which Dr. Nonheim is very passionate about, and this could help hopefully on the national level. So if you can contribute to that, so they can try and make change too. I think I'm allowed to promote that. I guess you can edit out if I'm not. All right. So finally, we had invited Dr. Puri and colleagues to talk about disparities in lung transplantation. Now, this is something we don't really talk much about. So again, another topic in thoracic surgery that we may not know about, but is obviously relevant to us. So apparently, in the lung transplant recipient population, blacks in particular blacks with COPD die at a higher rate while waiting on the waiting list than the non-blacks. Do we have any ideas about how we can reduce this disparities in lung transplant?
So, like all of our topics, it's very complex, and these are just introductions to the disparities that we face. And I think that it really depends on the same principles that we discussed, that first of all, we need really good coordination and communication and trust built between our communities and our healthcare teams. And so this means getting the word out about transplantation as even being feasible, even on the list of care continuum, that many people would not even think of transplant when they're dealing with everyday stressors of low socioeconomic status. So we really have to leverage what we've done with other programs and try to get people thinking along the lines of advanced COPD care, that transplant is an option, and really start to populate our transplant list equitably. And then from there, looking at how do we reduce the death from while on the transplant list. I think that we identified it, but I certainly could not speak on that. I think it's really up to more research and more dedicated thought process on what are the barriers and what are the ways to mitigate those barriers. And again, so complex and so different at every transplant center that I think it deserves more time and research and thought. But at least we have the beginnings of this with this chapter by Dr. Randhawa, and really looking at the beginning of how can we launch research in this topic.
Well, I think this has just been a wonderful conversation with you, Sherry, and I look forward to trying to build on this. And I completely echo your passion about population health. I think that's something, if you can focus on that, and not just your what comes to you, and just remembering that we're taking care of all society, right? We don't want to just focus on those who may not have access to what the privileged have, I guess, for lack of a better term. So thank you for your time and for preparing this and selecting such wonderful topics. I hope everyone will have the opportunity to read this issue, and I hope we can have a follow-up one in a couple of years. So thank you.
And I thank all the contributors who made this work possible. It's been a great privilege to connect with everyone across the country to put forth this important work. So thank you again for the opportunity.
Great. Thanks.
Thank you for joining us for our inaugural Thoracic Surgery Clinics podcast devoted to the February 2022 issue on social disparities in thoracic surgery, Volume 32, Number 1. This series is available for individual print subscription with online access or individual online-only access. Visit www.thoracic.theclinics.com to subscribe. The series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on Twitter @Surgical Clinics, and you can subscribe to the podcast through Apple, Google Play, Spotify, or Stitcher. Thanks for listening.